Thank you, sir. And thank you all the chairpersons, speakers, and expert panelists and moderators for such an illuminating session. Now, we are moving to the next session on complex coronary. May I invite the chairpersons, Dr. T.S. Clay, Dr. C.G. Bahulai, Dr. Anil Podar, Dr. Anjanlal Datta, Dr. Amal Khan, Dr. Neil Bordoloi, moderator Dr. Dhiman Kahali, and expert panelists Dr. Vikash Nagarkar, Dr. B.C. Kalmat, Dr. Anand Kaur, and Dr. Siddhartha Mani to start the proceedings, please.
Welcome to this session, everybody, including the panelists, the speakers, the audience. And I hope that it will be a very interesting session. And I have been listening to the youngsters showing beautiful cases and demonstration of all the cases since 3 o'clock. And this is really a very wonderful meeting going on, Dr. Devabrata Roy. So congratulations to you and Dilip Kumar for organizing such a beautiful one, and also Shunandal. Now, in this session, there are 3 presenters, and we are going to see actually 4 presenters. One is a presentation on plaque modification, and the speaker is Dr. Al Fajid Umar and Dr. N.K. Halmi. So I would invite the first presenter to demonstrate their case, and I would ask fellow chairpersons to have their opinion also. So you can start presenting the case because we are running little short of time. Okay.
Hi, good evening. Greetings from
good
Malaysia.
evening. Yeah, good evening.
Yeah, so let me share our screen because, like you said, time's a bit short.
Yeah.
Okay, can you see our screen?
We can see you, we can listen to you.
Yes, we can see you.
Very well. Thank you. You can go on.
Excellent. Okay, this is the IVERS guided rota card PCI. Get my colleague here, Dr. Helmi, to explain about his patient's history.
Good evening from Malaysia. Thank you for this opportunity to share with you. This is a case of a 58-year-old gentleman with diabetes and hypertension who presented with palpitations and chest discomfort and was diagnosed with angina, and actually has 3 vessel disease, very calcified vessels, and he sought many opinions, all who suggested he go for bypass. And he was actually listed and scheduled for bypass, but somehow decided he didn't want to do that in the end and just defaulted, and presented at another hospital where our colleague Dr. Sanjeev Joshi performed successful stenting to the LED and circumflex. Rotablation was not used in this case. IVUS was. There was calcification, but it was not circumferential. So they were able to negotiate this with the new Wolverine cutting balloon, and stents were placed in the LED and circumflex as shown. He was then referred to Glen Eagles Hospital for PCI to the right coronary artery because it was felt that it was likely he would need rotablation for that.
So this is the image of the right coronary artery that we have. So from the word get-go, we were prepared for rotational atherectomy. It looked quite small to begin with. So actually we prepared a 7 French sheath, but in this case, we actually put in a JR 6 French. So we'll go for the recorded live case now.
So what wire have you got here, Fazi?
We have a Sion blue wire, so it's a soft wire.
Okay.
And then we're just going to wire down, have a feel. So it's a bit calcified. You can see the guide gets pushed out a bit. And it's gone down nicely.
It's gone down quite easily.
So just have a look at the ECG and the blood pressure and all this. So, okay, the fine cross can't, actually it's gone, it can't go down actually.
Yeah.
Okay, so I think we have to change this now. Okay, so the plan is let's just balloon a little bit first because it's very tight and the fine cross is unable to go down.
Balloon low.
So give me a 2O balloon. So this is a 1O short balloon because the 2O balloon will not be able to go down. And this is a 6 French JR 6 French 3.5. So the support also is not very great. What is the length of this balloon? Yeah.
5.
All right.
That will go down.
Okay, up here first.
It's inflating. 8,
10,
10,
12,
12,
1, 4.
14,
Okay, down.
down.
Oh, God. Up here again.
Inflating. 14,
16, 18.
16, 18,
Okay, down.
down. Oh, macam tu.
Oh, okay.
Is it getting stuck at the tight thing or is it getting stuck at the bend?
I don't know.
Dr. Al-Fazil, what is your plan?
Okay, so the plan here is that we're trying to balloon, and we'll use a 1O balloon and a 2O balloon, and even that it will not be able to get
Let's just pre-dilate the
fine
2O at the
balloon will
proximal
not be
mid
able to
segment.
cross.
Okay.
And we'll
And
take
in
it
this
from there. Lah.
picture here as
So what are
well,
the options
you
if
see
you
that we
can't?
use a
Yeah,
2O
if you
balloon.
can't, then the other thing
And
is
even the
to
2O balloon
rota,
here
that means we
is
rota bear.
not,
Lah. I'll try and wire
you can see
down.
quickly the
And,
balloon here.
and this is sometimes
So
why
you
we
are
call
finding
it
any
a
difficulties in
dilatable lesion.
progressing
Let me
the
just try
balloon?
gently. If you can't,
Yeah,
then
so
just
we can't
jam
get the
fine
even the
cross mid
1O
segment,
balloon down.
then we'll wire the
And the
this is
next
where
one
sometimes
here-
It is a Riori
we
balloon,
have to
Dr.
use it sometimes.
Al-Fazil. It's a
exactly
1.5
for this
Riori.
purpose when it's so calcified and
No,
it's
yeah,
What
the
is
first
the-
one,
also because the guiding
first one was
not very great
it's
as
a
well.
1O
Will the guide
balloon,
extension or
2O
something?
balloon, and then we use a 1O balloon after that.
Acha. And
So-
would you like to continue with this guide? Because from very
Okay,
beginning we
gently,
have been
4,
seeing that the
6.
guide has
Okay,
been going
inflating.
behind
2O balloon.
and
that's-
it is getting disengaged repeatedly. Would you
8,
like to be a little more comfortable?
Yeah, so that's a good point. We were discussing that retrospectively. Maybe a 7 French guy would be a bit more supportive. But in
6,
part the vessel was quite
8,
small, but we were prepared to
10.
use
10,
So it's really calcified.
You
it's
can
on
see
I'm
even
meaning that would you like
12,
to take a
12.
AL guide catheter because that will
Okay,
give
down.
more
So you can
stability.
see
It's
it's
a
really
long
calcified.
lesion and the
Yeah.
lesion is a very tight one,
an indication
calcified
for
lesion.
rota,
Yeah, I mean, Amplas would be a very supportive guy, but sometimes there's
Okay.
pros and cons in using a rotational atherectomy with a very strong guide. Sometimes you can prolapse the rotational, so it's pros and cons. So the plan here was whether I think we have to agree that probably the only way forward here is rotational atherectomy. But of course, we can't even get the fine cross down. And the second question was we were discussing with Helmi as well. Do you routinely use a temporary pacing wire when you do the right?
We keep it in the near the apex, not always we push it, but many a times we push it. And would you like to go for rotational atherectomy after balloon dilatation?
Yes, in this case, there's no other option. Even a 1O balloon. will
Because
not be able-
normally, Al-Fazil, we don't go for rotational atherectomy normally. If we plan for balloon dilatation, we don't go for normally because, if there is some dissection, small one even also, it may be problematic. Because if we plan for rotational atherectomy, we go for rota first, and then we dilate as necessary with different balloons.
Yeah, but it's a small balloon. It's if there's not much a dissection, we are comfortable with
Okay,
it.
sure.
Yeah.
Okay, go on, please. Yeah, go on.
Yeah. So sometimes only for OAS we have orbital as well, and that's when we don't dilate. Sometimes I dilate because to allow the distal flow to be better. In this case, we didn't use a temporary pacing wire. We used an IV aminophylline. So we gave 250 milligrams 10 minutes prior. And so nowadays we try to stay away from putting temporary pacing wire because that can itself cause other complications as well.
Okay, so the plan here is since we can't get
So,
anything
the
down,
next,
what I'm going to do is I'm going to push in the fine
Because
cross halfway down.
we can't even
And
get
from there, we'll
we
try
wanted-
and wire the
we
rota
wanted
for
to
the
rota-
rota down, and we take a
do rotational
1.25 down.
atherectomy.
So this is
easily,
actually a
but
really
even
good
the
case
fine
because now
cross
that
will not be able to go
it's
down.
really
And
it's what we call
so
non-dilatable
what we
lesions.
had to do is that
Non-crossable.
we
as
just
well,
had to
yeah.
jam. We had to jam.
Okay,
the
so
fine
while
cross
we wait,
side again. and then we will
So what we'll do is that we'll prepare the Rota Pro 1.25 burr, and then later on, once the Rota Pro is ready, then we'll trap the fine cross. Then we'll remove the thing, and it will wire the.
Because
the
we
Rota
can't
Pro
even get the
down.
fine cross down.
Let's open up the Rota Pro.
So
this is
so that was the
new
initial
device,
plan, was to
new
use,
atherectomy device by
Rota, but
Boston.
you can't get the fine cross down.
It's been out available in Malaysia only this year.
The Rota Pro device.
So the difference that there is no pedals for the Rota Pro, but you have a button, a knob button, and
So
then you have.
you activate the rotation by pressing this button here.
Correct, yes.
Yeah.
So because it's very tight, even one balloon can go down, what we'll do is we'll try and jam the microcatheter mid segment, wire this across. So that's the first challenge, to get the wire across without a fine cross. Second challenge here would be to make sure that the rota goes through and the rota does not stall as it goes. So I'm going to get the fine cross. I'll try to
He
get the fine
had
cross across
an
if it's possible.
anesthetist, but what he also did was he gave a
Let's
few
see. So the fine cross
aliquots of atropine.
is unable to go down. Okay.
Pass with the rotator.
I'm going to remove this wire.
Helped, so with the aminophyllin and the atropine, we didn't have
Looks like it's gone a little bit further.
reduction in heart rate. With,
So trapping balloon out.
Just monitor the heart rate. and
Stable.
all that.
Okay, look at the heart rates of one and try that and see whether that
But
works.
now, because we can't get the fine cross down, we remove the wire from mid RCA.
Anyway, it's crossed anyway.
Oh, it's crossed, it's crossed.
Rota 4P from the mid
Well,
RCA.
So,
Wait, let me just have a look. Are we in the main artery? I think we are, right? There's no branches there.
bagi dah token tu. Bagi dah.
Iliocranial, please. Iliocranial. Sure.
Heliocranial Mio, thank you.
And the ECG, tolong baiki, Yeah.
One, baik ECG one, tolong.
So now we're just wiring
Here's
with the
the token.
Rota 4P wire with the fine cross only at the mid segment, because it was an uncrossable, undilated.
So but just gotta be careful when you remove the fine cross.
I'll just
Lou-
hold
yep,
this
thanks.
for you. So,
So, okay, just make sure there's no king in the wire. Don't lose our wire
We will
position.
use,
So we take a 1.25 burr here. Got to be very careful not to stop.
Well, it's like a single. So now it's a rotablation procedure.
What we'll do is we'll advance the rotor, and at the same time you pull back the thing here as well. So it's a forward and backward
So
movement,
it's a single operator.
and at the same time, so it's a single operator. Everything's well controlled, so that you don't need to, even if you don't need to depend on your nurse. This is a very controlled procedure, lah.
So you have one hand and
so
the other
you're
hand. you
advancing
have
with your left hand and you're
brake,
pulling back the
defeat.
same
Correct.
amount with your right.
Correct. So if
So you can
it's a wrong, if it's not the right amount of tension, you will see your guide either get kicks in or get sucked in. But if it's all right, then you will see that it's quite equal.
Oh.
Okay, so Healcaon, what we're going to do, and help me as well, we're going to rota maybe mid segment first, the first proximal to mid,
Rota Pro, you
and then once from there to the mid segment, and then we'll come back.
do proximal.
And then once one or two runs proximal, we're okay. We're going to push it down mid segment, and then for mid segment, we're going to go down. That's where it's really, really tight. Let's hope it goes. Okay, so 10 seconds, yeah?
Okay. All right.
Okay, slightly bready, but it's all right. Not that bad, but 47.
So we saw.
Yeah, so we got to just be careful. If it does goes bready, you can give some atropine.
Yeah.
But for now, it's all right. So let's try it one more time. I'm going to try and push this burr back a bit. Too close, it's a bit uncomfortable. Okay. So now we are quite nicely positioned, quite far away. We'll try it again and see. 10 seconds, huh?
Ten seconds.
Really tight. I'm going to push a bit more this time.
Okay.
We're going to be careful because as long as I don't push it more, then I don't think I'm going to cross it. 10 seconds, Aika.
5 seconds.
The wire is a bit,
Oh, it's come back. Eh?
yeah. This is the thing. Yeah, the wire is a bit bent. Huh?
But do you think now that you've done that, you're going to be able to get more equipment down? And
I think so. I mean, the only problem now the wire is bent. The other option that we have is, I mean, it's not ideal, it's just to take a balloon now.
yeah.
No, because we've already tried and the wires come back a bit.
You can't proceed with the wire like this, right? It's not.
It's a bit dangerous, like you might
Yeah.
cut off, But okay, so what I'm going to do now, I'm going to push this wire in. Yeah. Buka the keeper, bro.
Okay, so what we just showed is that there was, we used the Rota Pro console, which is much easier. I find that it's a very controlled procedure, and it's a button you press, so you don't have to keep your leg on the pedal all the time. Now you just press it, it goes, it starts to rotate, and then you push in the advancer back and forth. I think, and we normally use, I normally use as a single operator nowadays because it's easier for me to control the devices. There's a few ways where you can use a single operator with or without a Dynaglide. So the plan is a 1.25 burr, and if it had problems going through further, I would use at a higher speed.
So तसं पुष्कळ आहे ना तुम्हाला.
Sorry, so basically that was the plan, but because the wire prolapsed, I'm trying to go with the balloon again. If the balloon does not cross, then I will use it at a higher RPM. So let's just show you after this.
Would you like to take a picture?
So now let's
show a picture at this moment here.
Yeah, there's a picture, but I did not show it to you, but it's okay.
Yeah.
The flow is fine. But we did a lot of editing here.
So now now we have an issue. We still got some stenosis there. Let's try whether the fine cross can go down. If it doesn't go down, then we have to take a balloon.
No problem.
Okay, let's see whether the fine cross goes down. If it goes down, that's good. Then we can change to a. If it goes down, can I have a Sean Blue extra support? This. Helmi, can you come here and hold my guide? Hold my guide, nah?
Okay.
So I push it down. Wow, can't get in down as well. But it's much lower, much lower now. Okay, so okay, give me the extra Sean Blue extra support. So then we try a small balloon. If cannot, then we have to change the guide to a 7 French and all these other stiff options.
What guide do you want to take at this time?
Everything.
I would
To change
Nice, beautiful.
guide.
I would
Beautiful, went down nicely.
seven,
Okay, up here, bro.
It's either a JR
inflating.
or an R plus, but I
12,
do not like
12,
such a supportive
16,
14, 16,
Rota. Sometimes there have
18,
been
down.
times when
down.
it's too much tension on the
Up here.
Rota, you can go into
Inflating.
cross. So it's the pros and cons on
14, 16,
18,
18,
down.
down.
but I
Give
think
me a 1.5 balloon.
1.5 balloon, please.
And Ivers, can we open up the Ivers?
16,
make sure that
18,
when every time you use
Okay,
a
down.
small burr, you do not get into trouble of getting.
Beautiful. Let's give prepare the Ivers.
You got to be careful.
This is a 1.5, and then if this cross, we take a 2.0
And
or 2.5. This is okay, and then everything. Ivers opened. Okay, up here.
Oh, beautiful.
Beautiful, beautiful.
Okay.
1, 2, 1, 4,
14,
16,
16,
18.
18,
Down.
down.
Up here.
Inflating.
18.
14, 16, 18,
Down.
down.
Up here.
Inflating.
Is it the
14,
same balloon,
16,
1.5?
18,
Down.
yeah, we
Alright,
went
beautiful.
sequentially from, I think it's a
Beautiful,
0.85 balloon
Nice.
to a 1.5 to a 2.0,
Okay, so-
and then we use a
Okay,
Wolverine cutting balloon after that.
Okay, beautiful.
Yeah, so basically it was an 0.85 balloon.
So we have to decide.
Basically it was an 0.85 balloon and a 1015 2025, and then we use a Wolverine cutting balloon. Regarding to your guide, I'm not sure whether you can hear this now quite clearly, because it's always a pros and cons when you use such a supportive guide for Rota, especially in 1.25 burr. Sometimes when the guide is really strong and you have a 1.25, there has been cases also where too much force pushes the Rota down and you get stalled. So I think it's a pros and cons, because when you don't use such a supportive guide, if there's too much tension, the guide goes behind. So my plan B for this case, if I can't balloon this, I will use a higher ref. So I'll probably use like 200,000 and try and slowly try and rotate because it's a really calcified lesion. Okay, I'll now show you the next image now.
So
What
we
is
have to
your-
decide whether option 1 is DCB, option 2 is 1 short stand, 2 long back, or option 3 is 2 long stands.
What is your impression?
So
Is
we'll
it a
decide from the
calcified
IVERS.
lesion?
If there's also
Doesn't
plug in
look like
between the
calcified.
second and third lesion,
Yeah,
you might as well just
It doesn't look like calcified, but it's very
two long
calcified.
stands. I think because I think the stand will go down quite easily after we Wolverine it. Okay, coming down. So okay, it's actually Sanjeev is correct. Vessels are huge. It's 1, 2, 3, 4.
Yeah. It's a huge vessel. Yeah.
Beautiful. Can we go down? Can we go down a bit more?
You can take a, you
Okay,
can.
I can't go down
guide
below
is
here because there's
receding,
some
yeah.
calcium
You can
here.
take a
But I think that gives
second
me
bed,
enough
you
information.
know,
Let's
bed.
let's IVER.
Yeah.
Yeah.
So we have to decide whether
Okay, so this is the IVERS run, and you can see that it was very calcified in the mid segment.
Yeah.
There is, I mean, once the rotor can go, once the balloon can go down, you know it's calcified. And also the 2O balloon when we used much earlier was not even, it was a dog boning, so it's severely calcified. Although it didn't look like it initially, but I'm glad that we have all the devices. You can see it's a concentric calcium, and the mid segment here where there's cracks. So you can see very well the cracks there. And it's concentric and it's calcified all the way. So sometimes you may not, because the left looks more calcified, but it's actually, look at it, it's just concentric calcification, 360 degrees. And I think there's no way you can do this successfully without a rotational atherectomy.
Yeah. It's a 360 degree. Would you like to take a bigger bar at this moment?
Okay, so that's a good question. So we've used a Wolverine after this. So we take a 3.0 Wolverine, and it seemed to open quite well. I think if cost is not an issue, you can use a 1.75 burr now, because since we know that the size is quite large. But if I'm going to go all the way, then I would change to a 7 French. So here we use a
Wolverine is a very good balloon.
Replace the flagstone cutting balloon.
Yeah.
And you've enjoyed using
Wolverine
this
available
doesn't
in-
it?
Yeah, it's very nice.
Yeah. We have also
it's more
Wolverine balloon we have been using for the last
safe
2
as well.
months. Yeah.
It's on Emerge
Yeah,
NC.
we like it a
platform.
lot. I mean, we
Yeah.
used to use like
profile.
flagstone and
Okay, let's see how smooth it goes down.
Our
Yeah.
favorite wood cutting is
Let's
Wolverine.
see.
So we use a 3.0 Wolverine up to about 16 atmospheres, and here you can
beautiful.
see that
halfway here.
a lot of
Okay, so
calcium,
it's
so
quite
we
calcified here.
then use
Let me
the guide
see how far
extension.
down you can go down.
So we needed to use
this
the
is a
guide
3.0,
zilla.
isn't it?
Yeah.
We have
But let's go up here
all
first.
Okay.
6,
all the device that
8,
we needed. It's-
10,
But
12.
I mean, since the balloon
10,
opened quite well, if there was a
12.
dog boning
Okay,
in
so
Wolverine, I think
full.
I may consider having
Okay, down.
12.
rotor.
Down.
So you can see the very
And
calcified
then
below
nowadays,
there.
there's a lot of atherectomy devices available.
Okay,
So,
down.
you know, in Malaysia we have.
Let's see whether it goes down further down because it's very.
OS,
Even the IVERS couldn't take that bend just now.
So you can see it's
Okay, up here.
still calcified. So we
Plating.
use a guide extension.
2,
6,
4,
6, 8,
6,
10,
Normally the
12,
the Wolverine
14.
will go up to 6
10,
slowly, and after that you go
12,
quite
12,
high.
14.
Okay, down.
Quite
14.
going up.
Okay, so the plan here is we'll try to get it down.
You have to
Again,
be
if you can't go
careful,
down, might have
and
to use
also maybe
Guidezilla
slightly
Guidezilla
undersize
in
it,
2.5
you
because
know,
it's quite calcified here.
0.7
And,
or 0.8.
okay, one more time here.
Plating.
Super calcified.
It's
2,
really, I would, I didn't think it would be
6,
that
8,
calcified,
10.
but
6,
the whole
8,
vessel
10.
was
Okay, down.
very calcified
down.
because it's concentric.
Stand by a Guidezilla for me.
Yeah.
I'm going to get the balloon down in front
There
of
is
the
a
Guidezilla.
360 degree calcium over here.
Yeah.
But your initial bar has fractured the calcium successfully, you know. There was fracture. It was visible that there is fracture, you know, at 1 o'clock, 11 to 1 o'clock position, there was fracture, you know, and it is a 360 degree calcium.
Yeah, so that's why it's possible for us to to proceed further.
Yeah.
Because it's very rare that it's very rare to get small unable
Okay,
to get a
nice.
small balloon down,
Okay,
or
up here.
even
So low pressure,
a
2,
rota
4,
down. So
Okay,
it's
inflating.
really tight.
2,
I'm glad we had all the
4,
devices.
6,
So once we had the guide zilla down,
8,
and we advanced the
8,
guide zilla
10,
using the
10.
balloon to support and protect it.
down.
Down.
And now with because there was some lesion there, so
Up
we
here.
decided to
2,
put a
4,
long stand.
Inflating. 2,
And then we used
4,
a 3-0 Wolverine, and
6,
we cut it, and it
8,
looks full,
10,
so we
10,
decided to proceed
down.
with stenting. So the next, after we done a 3-0 Wolverine, we went to stent. So we use a Synergy stent. It's an everolimus eluting stent. So it's, the polymer is gone about 4 months. So when it's no longer needed. So after the completion of the drug elution at about 3 months, and the polymer is applied on the abdominal side, so to promote healing inside the vessel. So now
So most likely we need 3 stents anyway because it's so calcified. So it's going to be 3-0, 3-1, and the last one 3-5 lah. Sanjeev, you okay with that? Yeah. But this one we go low pressure lah. We go low and then we pull back, go high pressure.
So here we needed to use the guide zilla to get all the stands down. It's very long stands. It's
Capture that. Capture that.
You are planning to have 3
Small test,
stands?
bro.
Yes,
Small
yes.
test. For here lah. No, can pull back a bit. Pull back a bit. Okay, up here, up here, up here, up here now quickly.
Inflating. Stand deployment. 10, 12, 10.
Okay, down.
11, down. 11 nominal.
I'm pulling back the guide zilla. Okay, up here.
Inflating. 10,
12.
12. Down.
Okay, down.
Okay.
Pulling back the guide zilla for a while.
You want a 15 max so you can see better? Or
Okay.
You're right.
Okay. Wait, wait. Okay, looks okay here. Okay, yours.
Okay.
Go.
Okay. Stand deployment.
1, 2.
2,
1, 2, 1, 2.
12,
1, 4.
14.
Okay, down.
Down.
Put back my wire a bit. Okay, up here.
Inflating. 16.
Okay, down.
Down.
So then we got another stand down up to the proximal side.
Yes.
Okay.
Okay, we can move this wire.
Okay, so then this was the final IVUS. So actually the distal and proximal is well expanded. Slight under expansion in the mid segment. So we went with a 3.5 NC up to about 24 to 28 atmospheres. And so it's actually very nice on the distal, and the proximal mid was slightly under in this IVUS. Then we took a 3.5 NC. How high did we go? 24 to 28. So after this, we followed by the NC balloon, and then the final shot.
Okay, final shot, yeah? Okay, yours. All the way down. All the way down. Thank you. Epicranial. Mid segment slightly, but I think everything we said okay lah. Okay, okay.
Oh, nice.
Okay, nice, beautiful. And one epicranial, we're done.
So we decided to accept the results. The minimal stent area was about 6.4, the tighter segment, so it's over 5.5. So we decided to accept that. The thing that we were discussing was to use an OPN balloon, but we didn't have it at the time. But the other option is to use an OPN balloon. So to take home message here, I think for calcified lesions, you will need a range of devices to have a successful PCI. And in this case, I think it'll be very difficult to do a complete without using a rotational atherectomy. It's always a debate whether you can use a bigger rotational atherectomy afterwards. Of course, it's about cost and all that. You need to be comfortable with using rotational atherectomy and cutting devices. And I think most of the time we will still use it assisted by intravascular imaging. So that allows us to go more aggressive in the post-dilatation and the stenting size. And RotaCut has a better predictor for optimal stent expansion.
So it was fantastic case. Well done. Very well done. Thank you very much. Another important message lies here that in a calcified lesion, narrow lesion like that, if you go by balloon only, thinking that there is no calcification, there's chance of dissection as well. So there is dissection from both from the balloon end as well as from the perforation from the rota end. So you have to take care of both. Thank you very much. It was a well done and very adventurous case. Thank you very much.
Thank you.
Thank you.
Dr. Sanjeev Rai, our next presenter.
Good evening, sir. And I think my slides are visible.
Yes, very much.
So good evening, and I'm going to present some complex case here, which is complete revascularization using multimodality approach under IVUS guidance. And my case has though some similarities with the last case that we had in the live case. So this is a 72-year-old gentleman, a political heavyweight, and who wants his own way to get things done. He had a rest angina in the month of December, which was managed conservatively at home. On 1st Jan this year, he was hospitalized with feeling of suffocation, detected to have hypoxia. ECG showed significant ST depression in the anterior leads, and the NT-proBNP was 507, while the TROP-T was significantly elevated, that is 3867. Next day, he shifted to Jaipur to another facility and underwent an angiography which reported left main plaquing with 2-vessel disease. The options are revascularization discussed, and on the background, he is a diabetic, he has hyperlipidemia, he's a reformed smoker and tobacco user, has had bronchial asthma, but did not use bronchodilators in the last 5 years. So as he gets away with his own wishes, so he remained on medical management with multiple consultations at most centers in various parts of
it was
the
February
country.
2002. It was February 2021. Did you have any COVID test?
Yeah, we had COVID tested. It was completely COVID negative. Several times he had undergone in each hospital that he was admitted. So echo showed, mild LV dysfunction with hypokinesia and sclerotic aortic valve. I saw him on 5. This was the first interaction with him when he, with an intention of angioplasty, got admitted. And I finished his baseline angiography, and then on the table, he withdrew his consent. He went again for medical management, but then about a month thereafter, he had some bleeding from the external ear. DAPT stopped and downsized to clopidogrel aspirin from ticagrelor. He was reevaluated on middle of March, where echo showed surprisingly this time it was instead of sclerotic aortic valve, it was reported as calcific moderate AS with mild AR and mild LV dysfunction with same valve motion changes as earlier. His repeat angiography was done then again in another facility, which showed some left main plaquing with 3-vessel disease and advised AVR with CABG. He had a meeting with the cardiac team in that hospital, but ultimately he decided not to go for surgery. And yet he was having recurrent angina. So he came to me again about a month after with an idea of getting a PCI. So let me show you the angiography done a month earlier before his last hospitalization with me. And this is here the, the left main with minimal calcified plaque in the distal part. And the circumflex is almost normal. The OM has mild to moderate disease. The OM2 and OM3 are quite large and normal. But if you look at the LAD, and its tortuosity, it's heavy calcified. There is an ulcerated plaque out there and somewhere close to the diagonal. The diagonals are diffusely diseased. And if you look at in the iliocranial towards your right hand of the screen, you can look at the tortuosity of the LAD and the proximal LAD. His right, he had an osteoproximal plaquing, and there was a tight bifurcation lesion, 110. And you can look at the angulated origin of the PDA out here. The PDA appeared to be about 70% origin. Ostia was large, but not much of territorial supply. So his case was planned is an ST score of 1.5, syntax score 29, syntax 2 was 32. And as he had already withdrawn the consent for bypass, he only wanted to undergo an angioplasty. So with that, we decided the plan And plan was to deal with the RCA first and then the LAD. So this is a bifurcation 110. And as you can see here, the, takeoff of PL is very straight, but the origin of PDA is very angulated. And there is an dilatation out there, post-stenotic dilatation in the PL, and which would make wiring of the PDA slightly cumbersome and difficult. So I decided to go for provisional single stent crossover strategy and image guidance. With that, I actually took a 7 French catheter. There was significant damping, as also with 6 French. You can look here, 6 French catheter, again damping, but the lesion osteoproximal was not looking very significant. So anyway, I had to, wire the PD. So I thought I'll take the support of microcatheter. So this is Corsair microcatheter wire going straight into the PL. I crossed with the Corsair. I reshaped the wire so that I could, enter the PDA. It took me some time because of the angulated origin, but finally could cross through the into the PDA. Balloon dilated. This is a semi-compliant balloon, 2 into 12 and 2.5 into 15. The balloon was repeatedly slipping out here. You can see the watermelon seed effect, but 2.5 longer length did make some impact, yet there was a significant residual stenosis. So at this point, I did an IVUS, and the IVUS here, if you look at here, at the tightest point, there was 2 quadrant of calcium here. Possibly that was making the balloon not to expand and slip. And there was a calcified nodule just proximal to that lesion. So with this, I took a Wolverine here. This was 2.756. I took a shorter length because I could actually do more of focal balloon dilatation at higher pressures. And with that, the lesion yielded. And looking to my IVUS data, I could identify the landing zones. So I took a 2.5 into 28 stent and deployed at a low pressure. And then subsequently post-dilated with 2.515 and did a pot with 3.25 into 12. So after the pot, things looked okay, but then while this is the, IVUS I did, but there was significant stenosis at the calcified segment out here in the middle you can look at, and the area was 4.52 compared to 8.43 in the proximal. So I did again touch it up, but then again with the higher pressure dilutation, you could see, you could see that my PL, flow had compromised. As you can see there, while waiting, I could see the TME flow had reduced in the PL. So I wired the PL and then balloon dilated with 2.5 into 12. And this balloon ruptured, but I thought it opened up the studs. So I changed my strategy. Instead of kissing balloon, I went for a pot side branch pot because all I wanted was a flow in the PL. PL was not great enough to stent. So with this strategy, this is the final view we can look at. My PL flow was resumed and I could take care of the calcified lesion with Wolverine cutting balloon dilatation and good stenting. The valve area was good. And these were the final angiographic results. With this, I move to the LAD.
Dr. Rai, what is your argument for not putting in a wire while you are putting the first stent in the PDA?
Well, if you look at, I discussed about the takeoff of the PL.
Right angle, it is okay. Right angle, so it is okay. But
PL was
chance of plaque.
Yeah, PL was straightforward, and it was not disease. This was possibly a carina shift which caused, and PL was not significantly diseased. So wiring, even if I needed, would have been easy. So I did not wire. If it is not diseased, I usually don't wire it. Not always.
And another question, Sanjeev. First of all, very nicely you have done the right coronary. Dhiman here. Regarding the calcific nodule you mentioned, normally we do know that calcified nodules, only the orbital atherectomy works well. Neither rota nor IVL nor any cutting balloon works. So any comments about that?
Very rightly said, sir. But if you look at here, the calcific nodule site was not occlusive. It was just a calcific nodule there, but it was not too much protruding into the lumen to be very occlusive. So I did do a cutting balloon, and cutting balloon won't score the nodule, it will just make the contralateral wall to expand. So all I needed was a good stent expansion at that point. It was not very tight enough to do an orbital or rota there. And it was a very discrete lesion out there, not a very significant one.
Yeah.
So shall I move to the LED?
Yeah, sure. Well done, Sanjeev.
LED was more tougher, and that was, a little bit easier lesion. So here you can look at the tortuosity here of the LED, and it was very heavily calcified. Mind you, I'm not sure you're able to appreciate here the calcium, but it was very heavily calcified. And there was an ulcerated plaque, and all of the diagonal were very diffusely diseased with very angulated takeoff. So, the challenge is anticipated. It's a calcified vessel, long segment, tortuous, ulcerated lesion, just proximal to the tight angulated lesion, diagonal acute takeoff. So I anticipated some wiring issues, and obviously because of the calcium, it would need a plaque modification. So I tried to wire, the wire, after wiring, nothing would go beyond that angulated bend, not even a 1.25 balloon. I did not open.
What were you gave, Sanjeev?
This is workhorse.
You gave, Sanjeev?
This was workhorse wire, but nothing would go beyond here. And this was very tight.
Okay.
I did not try the Nick Nano, but 1.5 won't traverse this. 1.25 balloon did not traverse. Fortunately, I was able to put the Corsair up to this point. And after the Corsair, I could, once Corsair there, and I needed a plaque modification looking to the calcium. Through that Corsair, I could push the, rota wire distally. And I was very much prepared for,
excellent,
going for a rota. And this was a rota. You can look and now appreciate the calcium here.
Yeah. It's a hugely calcified artery, hugely
thick. And this is a 1.5 burr. Now, challenge is 1.5 burr also is not crossing that very angulated bend. You can look at here my several runs, and this is even I increased my rota burr speed from 16 to 20. It won't cross. So I'm led with this challenge, but unfortunately, and then I took out the wire. Since I had a high speed, rota here. So obviously anticipated no flow. You can look at here, absolutely no flow. A lot of embolization must have gone distally. At this point of time, when I took out the wire, there was a drop in pressures to 70%. Hemodynamics, low normal, inotrope started, patient was intubated on mechanical ventilation. And with that, the saturation and hemodynamics improved, and I thought to resume the procedure. So the best way to get away with this for me was downsizing the burr and maybe use a high speed again if required. So this is a 1.25 burr, and 1.25 just barely crossed, but one has to be very careful because this angulated bend, the burr gets entangled and, entrapped in that. So had to be, this is not the actual picture. So had to be very gradual and making movements. I could cross this and you can see some flow there. And then again, I upsize the burr to 1.5 to make further passage. So these are polishing runs in the right side, you can see. And having done that, still no flow. So if you look at here, still no flow, balloon dilated with non-compliant balloon, some flow there, but not significant. At this point of time, I took again an OPNNC. OPNNC also did not make much impact. There was still, you can see here a residual, indentation. So though proximally and distally it did open up, but still that point, significant narrowing. So at this point, again, since I had the imaging catheter on the table, I did an imaging, and you can see, although my rota and OPN balloon did make an impact, but still I had at this tightest point, significant amount of calcium, which was more than 3/4. And at one point, it was almost like close to 300 degree. So here I thought I need to, make the stent expand more. I went for an IVL. This was 2.512 IVL. Pulses distributed mostly in the tightest lesion, but then equally in the proximal and distal parts of the tightest lesion as well. And this is after the IVL, the flow had resumed, and you can see the TIMI3 flow. I used again the OPNNC to prepare the bed well, and then went for a stent. This is a single stent covering right from the osteo to the, to just proximal to the D2, covering the entire tightly diseased segment, and then post-dilated it. And after post-dilatation, these are the views. I had a significant gain in the lumen, and it was very optimized. The area here was 7.69, even in the significantly, although it was slightly less, maybe around close to 75-80%. But I thought of accepting this. The only thing is that there was in left main some dissection flap, you can see. So here, initially I had no flow, so I did not use an OCT. And here I just wanted to clarify the left main, dissection. But then additionally went through, I think it was well deployed and expanded stent. What you can see here is the left main, a small flap, and perhaps this was because of my rota backing out when I was trying to cross the tightest part. But this was quite an acceptable dissection. I thought not of stenting it, because most of the time we do follow this small amount of dissection, not extending to the media. The arc is small, not much. So these are the final images. So he's in the hospital course. We had extubated him an hour, but again had to re-intubate because of an acute exacerbation of his airway disease. Then again extubated him next day. There was periprocedural cardiac enzyme rise and decline in LV function. He was discharged in 48 hours on DAPT, high dose statins, fortnightly evolocumab, ivabradine, spironolactone, and low dose beta blockers. He has been in follow-up for the last 2 months. His LV function has improved to mild LV dysfunction. He has resumed all his activities, doing actively yoga and walking about an hour. So the salient points of this case, this was a complex high-risk case which can be performed successfully if you can plan and with image guidance, and maybe sometimes you need a multimodality approach. Pre-procedural availability and familiarity with all required hardwares is needed to perform such a chip case. Multiple runs of intracoronary imaging not only help you to guide and titrate plaque modification, but also guide to switch over between different techniques, be it rotablation and IVL accordingly, to exploit its beneficial effects. Plaque modification of heavily calcified arteries achieved by combination of all, sometimes cutting, rota, and lithotripsy. Patience of the primary operator plays a key role for the successful outcome of such a case. Hard calcium is not so hard a line between CABG and PCI. Thank you.
Wonderful case, Sanjeev, beautifully done. And really, at one stage, we are thinking that it is not doable. But you have shown that really CABG patients also the interventionist can do, and we are seeing one after another beautiful cases by the operators, both by our guest operator and you. And, it is really very well done. Now, in this IVL, this is known as rotatripsy, probably, that rota followed by this dilatation with the IVL balloon. How many pulses you had to give in this patient? Because there was no artery, it's actually 360-degree almost calcium, 300 to 360-degree calcium.
So
everything, heavily calcified.
Heavily calcified. So if you look at only at one segment that was about 15 millimeter, which was the most non-yielding part,
yeah.
I distributed nearly about 40 pulses out there, and remaining 40 I distributed in just proximal and distal to that, because those were already scored and modified by the rota and OPN balloon earlier. It was only selectively at that tight point where it did not, the rota and OPN did not work very nicely. So that's why I said, it's all combination. Sometimes imaging helps you to decide to, selectively use which strategy where.
Sanjeev,
you didn't leave anything, yeah.
Hello, Dhiman?
Yeah, you are audible. Yeah, you are audible, boss. Yeah, we are looking for you. How are you?
Sorry, I was stuck up in some case.
Okay.
I just want to ask Sanjeev, it was a very complex case, particularly, LED, I think was much more complex. I just want to ask you that he used rota bar up to what diameter?
Sir, initially I selected 1.5. Then I had downsized it to 1.25 when it was not crossing, then again upsized to 1.5. But I did not use more than that because, already a lot of atherosclerotic debris had gone. The bigger the size you use, more debris and no flow. I already had a no flow there. So all I needed is after that use a OPN balloon so that I can reduce the further embolization of the calcium and improve in the no flow. I mean, in some cases, had there been no slow flow or no flow, maybe I would have been tempted to use a 1.75 or 2 burr in that.
So were
Sanjeev, it was a
were you
fantastic
concerned
case.
with the tortuosity where you use the rota in this patient?
Yeah, it was the most important part of that. How did you overcome the tortuosity? The initial stage, you just use the cochlear and just push the rota, and that was probably the most important part of obstruction.
Sir, in such a tortuous lesion, all we need is, as I said, I mean, you have to go very, very slow, very woodpecking movement, because if you select, your bird selectively over, does that, you may have a perforation. So we need to go very slow. You have to be very patient and multiple runs, and take out the burr, let the artery come back and slow. So go back and forth. I mean, you have to give breathing time to the artery.
Yeah.
Go very slow, just do it, touch it, come back, give a breathing time, then again do it.
And it was amazing also, Sanjeev, how could you pass the OPN balloon? It was and I must inform you, all of you at this point of time, that more than 500 participants, delegates and panelists were watching your procedure, Sanjeev. And our guest operators, Al-Fajir and Dr. Neem from Malaysia, the beautiful job you have it has been watched by 500 plus participants from all over the country. So that's a big thing. And it was amazing to see how you managed to pass the OPN balloon, because it's a tough balloon. And in this aperture, it's very difficult to push. Hats to you that you were able to push the OPN balloon in such a situation, because there was nothing at the bend of the proximal LAD except for some chunks of calcium,
So Sanjeev, another
It was
thing
wonderful to see.
Sanjeev, it was a very heavily calcified tortuous lesion. So before the OPN balloon, I would have used the IVL.
Sir, IVL would not have gone. And this is OPN balloon I did after the rota. So it was not easy as it looks like.
Yeah, it's very difficult.
I would
as
say
I was telling,
I mean, these pictures are all edited pictures. So just to highlight the salient features. So it's not an easy job.
They really don't show the difficulty.
We can understand how difficult it was. Yeah. Therefore, I was telling that to push a OPN balloon in such a situation is also very tough.
Yeah.
It's a very tough balloon. Yeah.
But using a grand
Okay, very nicely done.
Yeah.
Very nicely done, Sanjeev. Dr. Al-Fajir and your team, any comments about this particular case?
Yeah, it's a beautiful
How would you have liked to do this one?
Yeah, I mean, we were just discussing. I mean, the IVL just arrived in Malaysia, so we have one case that we will probably do on Tuesday. But I'm happy to see that you have all the range of device with the with the rota trip C and OCT images. So it's beautiful case. Helen, what do you think?
Did you think about staging the procedure, because the right was not that easy to do? And then you think about staging the
very good point, I think.
Yeah, I agree. That was one of the preconditions. As I said, he's a political heavyweight, and he had a precondition. He'll go once into the lab and never ever.
Okay.
A great case.
But beautifully done. Hats to you, Sanjeev. Yeah.
Thank you, sir.
Hats to you. In US also, Al-Fajir, they have got the device IVL about 3 weeks back, So Shamin was telling in a conference from Mount Sinai that they got it 3 weeks back. So anyhow, all of us have got it. And how do you feel about Rota Pro? Because in India, we haven't got it. I don't know, 1 or 2 centers have got, because Boston people were telling that they were bringing the Rota Pro. So, how do you feel about Rota Pro? It's much better to handle than the previous one.
Yeah, I feel it's much easier. I mean, initially I had some reluctance to change, because we are so used to the pedal, our legs and all control. But with this case, you just have to press the on button and then you move backwards and forwards. I don't have to think about making sure that my legs on the pedal. It feels much smoother as well, the whole console. And you've got a triangle to show deceleration as well. So I thought maybe it's a step up from the old Rota device.
Yeah, unfortunately, we haven't got it as yet. I have been asking the Boston people, why don't you bring it in our country? And they can have lot of sales also, Nick, because India is the market, very big market. So I asked
Yes.
them, why you are not bringing it? And it makes the job much easier for us.
Yeah, true.
Anyhow, beautifully done, all the cases. Very good, very good. Wonderful. Any more comments, Dilip?
Yeah, thank you, sir. I think we can move on with the next session, sir. We have already overshot the time.
Okay, thank you. Thank you. It was a beautiful session. And to conclude, it was a beautiful session and it was amazing to see such highly calcified, just junk cartridge being done in such a beautiful way. And Dr. Al Fazir and Dr. Sanjeev Rai and Dr. Al Fazir and his team and Dr. Sanjeev Rai have shown that how beautifully our interventionists can take up the job of, our surgeons. It's for the surgeons, but they have done it so meticulously and they haven't left anything, from rota bar to IVL to OPN balloon, all different balloons, Wolverine balloon, IVAS, then OCT, everything has been done, nothing has been left. And the previous case also from Malaysia, our friends have shown how beautifully they can do the job. Thank you very much, both the operators, and it was really a beautiful and amazing session to watch. And thank you, Dilip and his team, your team, for arranging such beautiful sessions. Thank you.